I'm Taro Takami from Yamaguchi University in Japan. My title talk is Clinical Trial for Decompensated Liver Cirrhosis. So exactly, we expand autologous bone marrow mesenchymal stem cells using StemFit For MSC, jointly developed by Ajinomoto Corporation and us and the Shibuya Corporation. So I will go ahead my presentation. So our target patients are suffering from liver cirrhosis. Cirrhosis caused by chronic inflammation of the liver due to hepatitis virus, alcohol, obesity, and other causes. When inflammation occurs, hepatocytes die, and this space is replaced with fibers. As you can see on the right, patients with cirrhosis have a nodular liver, and if you look at liver tissue, you will see that fibers have replaced original normal hepatocytes. The liver is an organ with a higher regenerative capacity even after rejection. However, once dense fibers are deposited as seen here, the liver loses its regenerative capacity. Only these pictures means fibrosis, and these fibers makes pseudo-lobular formation in cirrhotic livers. Importantly, same pseudo-lobular formation was seen in any kind of etiology. Therefore, we speculate that since liver is a regenerative organ, if fibers are removed, liver may return to its original state. Therefore, we focus on reducing fibers to cure chronic cirrhotic patients. This is our previous research in mice liver cirrhotic model. A mouse whole non-cultured bone marrow cells were infused from peripheral vein. Infused cells deposited along with fibers. Black dot means infused cells, and pink line means fine liver fibrosis. Following this, infused cells secreted MAP that dissolved the fibers. Based on Muir study, we have conducted autologous bone marrow cell infusion therapy for decompensated liver cirrhotic patients. Briefly, autologous non-cultured whole bone marrow cells, around 400 ml of bone marrow fluid, are collected under general anesthesia using same method of bone marrow transplantation for leukemia. And then we wash and concentrate bone marrow mononuclear cells, which are infused back into the same patient via peripheral vein by dripping infusion within same hospital day. As you can see, after the infusion, we found that change surface of liver irregular to smooth, suggesting improvement of functions. In fact, we confirmed the serum albumin level in these patients had improved significantly after the infusion. However, this autologous bone marrow cell infusion involves bone marrow aspiration under general anesthesia. So this therapy is not indicated in patients for whom general anesthesia is difficult. Therefore, we attempted to develop a less invasive liver regeneration therapy in which bone marrow mesenchymal stem cells having curative effect on liver fibrosis isolated and culture from small amount of autologous bone marrow fluid aspirated under local anesthesia and then infused back into the same patient by drip infusion. This less invasive liver regeneration therapy in which culture MSC were infused in intravenous infusion are performed to ensure safety. So far, we have registered 5 patients and then infused cells to 4 patients. This slide shows the result in 4 patients who received treatment. In the left is modified CHA2DS2 score comprising liver jaundice, ascites, encephalopathy, serum albumin, and proteromin activity. Therefore, lower score means better liver functions. CHA2DS2 score tends to decrease after the MSC infusion, but CHA2DS2 score returns to original level after 2 to 3 months. On the right, we are also looking at transition of serum albumin level. After the infusion, albumin increase was observed. However, this therapeutic effect did not last long. Although peripheral intravenous infusion (MSC) was confirmed to be safe, it's necessary to develop another way to enhance and maintain these therapeutic effects of MSC for longer period. I have mentioned earlier that we enrolled 5 cases and performed infusions in 4 patients. One patient could not be infused because the number of cells did not meet sipping standards. As seen on the left, case A is a patient with good cell proliferation and could be infused. And case B below, a patient with poor cell proliferation and could not be infused. After the examination of various causes, we found that one of the reasons was progress, senescence of bone marrow MSCs. We stayed with SA beta girl. The result was positive in case B, and the expression of senescence markers such as P16 showed a higher level. Cell proliferation curve is shown in lower right side. In general, patients with good proliferation have cell occupancy rate of about 90% in 100 hours. We think this kind of growth rate is right for our purpose. However, case B patient had poor cell proliferation. In addition, cell infection and other causes of poor cell proliferation was ruled out, and other cell surface markers and quality standards such as endotoxin test. I have listed 4 issues that were revealed in previous our researches. First, because patients on bone marrow cells are cultivated, they are different from allogenic cells, meaning that number of cells is limited. Therefore, it's necessary to produce effects with limited number of cells. Second, it's necessary to develop a medium and culture method that maintains quality of cells and does not promote too much cell senescence. Third, it's necessary to reveal the mode of action of MSC. Fourth, in order to widely deliver this treatment to patients, it's still necessary to conduct clinical trial and obtain regulatory approval. Keeping these 4 issues in mind, we have been conducted reverse translational researches. First of all, since number of cells was same, we changed the infusion route to the liver directly from peripheral vein. Former MSC from luciferase positive mice were infused directly into the liver. Top figures show infusion from peripheral veins, and bottom figures shows infusion from spleen and portal vein. Since hepatic artery infusion is difficult in mice, we decided on infusion to portal vein from spleen. The blood flow to the liver comprises the inflows of hepatic artery and portal vein. Both flows eventually merge at the center of the liver. Therefore, hemodynamics once inside the liver does not change much. As you can see, after peripheral intravenous infusion, many cells were captured in the lung and disappeared earlier. On the other hand, direct infusion to the liver resulted in more cells lasting longer in the liver. As shown here, for obtaining POC, we established and reported the first canine liver cirrhosis model by repeated carbon tetrachloride treatment. A repeated carbon tetrachloride injection directly into the stomach in this way, liver fibrosis can be expected to be induced in about 10 weeks. Using this technique, dog model was developed in which the infusion could be performed through hepatic artery using catheter, and then therapeutic effect could be compared between hepatic artery infusion and conventional peripheral vein infusion. This figure compares peripheral vein infusion and hepatic artery infusion in this model. At 4 weeks after MSC infusion, liver fibrosis had improved significantly, most in hepatic artery group, red columns. And therapeutic effects in hepatic artery group were also maintained even at 8 and 12 weeks. Although number of therapies is the same, hepatic artery infusion is more effective than peripheral intravenous infusion. Additionally, since bone marrow MSC express tissue factors on the surface, there is a concern that MSC have coagulation activity, especially in senescent cells. Therefore, we conducted safety tests in which 3 times amount of MSC were rapidly infused at 10 times the speed. We observed no particular change that promoted coagulation activity, but rather confirmed that results suppressed liver damage. And the additional concern is that hepatic infarction by arterial embolism may occur after hepatic artery infusion. As shown here, contrast enhanced CT were performed in dog model after MSC infusion. We cannot detect any infarction in this CT examination. On the other hand, MSC have immunosuppressive and anti-inflammatory effect. There are concerns that MSC may promote hepatocalcinogenesis because of immunosuppressive effects. Therefore, as shown here, we developed mouse cirrhosis model with higher rate of cancers. As shown below, MSC was infused 5 times at 2 weeks intervals. Finally, we confirmed that cancer bearing rate and the number and size of tumor was the same with and without infusion of bone marrow MSCs. After these efficacy and safety evaluations in animal models, we conducted clinical research to investigate the effect of change in the infusion route from peripheral vein to hepatic artery. As shown here, small amount of bone marrow fluid was collected under local anesthesia. MSC were manually cultivated in isolated system in our university hospital. And then we conducted procedure of infusing MSC through hepatic artery. In this slide, I would like to demonstrate result one of our cases. It's a case of 40-year-old patient with alcoholic cirrhosis. This patient had a Child-Pugh score of 10 points with decompensated cirrhosis. We performed cell culture without any issue and then infused MSC via hepatic artery. As shown in the lower left side, we confirmed that the volume of liver was increasing. As shown on the right, improvement of serum photomy activity and serum albumin levels were confirmed, also with decreasing Child-Pugh score. The next step is to develop culture medium and that maintains cell beta quality. In clinical study I showed you earlier, 10% bovine serum was used for culturing in normal medium. Finally, we have developed chemically defined medium jointly developed by 3 groups: Ajinomoto Corporation, our department, and Shibuya Corporation. Normally, MSC are cultivated with 10% bovine serum because cell proliferation and adhesion are poor without FBS. We thought that probably there are many components of bovine serum that are not essential for our purpose. Therefore, we assume that if only essential components are included in this culture medium, deterioration of MSC can be prevented. This medium contains only essential components and exclude non-essential ones. When cell culture is performed in this StemFit For MSC, senescence marker, and inflammatory cytokines are suppressed. In other words, it's possible to culture cell if its task associated with senescence is also suppressed. And culture cell has higher expression of TSG6, better known as one of anti-inflammatory proteins. And shown in the lower right, if higher differentiational capacity into adipocyte, osteocyte, chondrocyte could be seen. Overall, morphology cells are very small with a spindle shape that looks pretty good. Another important thing is that in our previous study, the cells did not proliferate and we could not infuse cells in one case. The cell proliferation ability of this case B patient did not increase with FBS containing normal medium. However, using this StemFit For MSC, 90% cell growth in 100 hours was noted. It's comparable to cells that were good in case A with normal medium. This is a very big reason for our choosing StemFit MSC in current clinical trial. So far, we have had various discussions with PMDA, like that KFDA. First, compatibility of standard of biological ingredients included in this medium has been confirmed in our discussion with PMDA. Second, as per our protocol, we have also verified the safety of process-derived impurities and non-cellular components. Of course, if SOP is difficult, final properties of final product will be changed. Therefore, be careful. Third, is a result of general toxicity studies, tumorigenicity studies, pharmacokinetic studies, and study to support efficacy have been also submitted to PMDA, and then finally have been accepted. Next point was to review mode of action of MSC. Cirrhosis can be regarded as one of various organ fibrosis. In general, organ fibrosis means that when epithelial cells are damaged, inflammation occurs, which involves infiltration of inflammatory cells, such as macrophage produce inflammatory cytokines. These inflammatory cytokines activate fiber-produced cells, and fibers are deposited to heal wound. This is a wound healing cycle. For example, in the liver, macrophage and endogenous Kupffer cells produce inflammatory cytokine, and hepatic stem cells that are shown in blue produce fibers in the liver. The space of this between hepatocyte and epithelial cells. As steroid cells produce much fibers in this space, cirrhosis has been developed. Therefore, we examine the effect of MSC on these component cells. First, regarding effect of MSC themselves. MSC themselves have gelatinous activity that dissolve fibers such as collagen, as shown on the left. And exosomes from MSC have effect of suppressing oxidative stress emitter. And the interaction with liver stellate cell is shown on the right. In comparison with MSC, P3P, this is a fragment during production of hepatic cell derived collagen is also suppressed. Also, we suspected that effect of MSC on macrophage is larger. Macrophage produce inflammatory cytokine in inflammatory environment. However, it has been also reported that MSC could make this phenotype change into anti-inflammatory and induce MAP expression that they are so-called fibrolytic macrophages. Therefore, we culture MSC and macrophage in a non-contact manner. In the result, we confirm phenomenon in which MAP expression was enhanced and the inflammatory cytokine TNF-alpha suppressed. Each of microRNA contained in co-culture medium, and we selected 5 higher levels of microRNA. As you can see, when specific microRNA was transinduced into macrophage, expression of MAP9 was enhanced in macrophage while suppressing inflammatory cytokines TNF-alpha or IL-1 beta. Thus, it's confirmed that adding this microRNA, as shown in the lower right, increases gelatinase activity. What happened in macrophage co-culture with MSC? Therefore, when geoanalysis was performed, ERF and 84 signals were suppressed. This transcriptional factor called 84 is also involved in ER stress. This 84 expression is simultaneously suppressed during transduction of this microRNA in right graph. Previously, it has been also reported that higher level of 84 may contribute to development of non-alcoholic steatohepatitis. Therefore, we assume that MSC may be effective on development of non-alcoholic steatohepatitis. Therefore, we examine MSC effect on murine model of cirrhosis of NASH. The fibers in the liver are seen in pink here. When MSC infused via screen, fibers are reduced. Regarding macrophage, number of M2, so-called fibrolytic macrophage, is increased after MSC infusion in the liver. We also examined effect of MSC on fatty liver, and they confirmed infusion MSC also suppress fatty liver. As shown in the lower right side, we confirmed that fatty hepatitis cell with MSC improve fat deposition even in vitro. Finally, we found that activity of PIP-alpha was increased. This means that fat is better oxidized in mitochondria, where fat is burned and consumed to produce ATP. This suggests that probably MSC not only have effect of reducing fibers, but also improving function of hepatocyte. Sorry, this is a little bit busy slide. By using this StemFit For MSC culture medium, we can cultivate good quality MSC with higher expression of anti-inflammatory cytokines and less senescence. Direct infusion of these MSC into patients promote beta oxidation in hepatocyte and promote phenotype switching that enhance fibrolytic activity in macrophages and suppress production of fibers in stellate cell and dissolve fibers through MLP activity. We believe that these complex mechanisms contribute to liver regeneration. Finally, we would like to discuss a little about pharmaceutical approval. I think that it's necessary to make effort to cultivate safer and lower cost. This is the Shibuya Corporation's isolator. This has a grade A chamber having incubator system and 2 pass boxes. These pass boxes will play role of grade C and grade B. Therefore, we can secure grade A aseptic condition during our culturing MSC around for 3 weeks. Moreover, we have also developed automated cell culture system using robot collaborated with Shibuya Corporation. This automated robot is in isolator for prevention of contamination, and this isolator connects with incubators for 3 weeks culture. And currently, we have manufactured autologous bone marrow MSC using this robot system in our clinical trial. This is the scheme of current clinical trial. The etiology of patients with decompensated cirrhosis is not questioned. The Child-Pugh score of these patients range from 7 to 12 points. The major change in this clinical trial is that corrected bone marrow fluid is shipped to the cell culture processing center of Shibuya Corporation, where MSC were cultured by robots. And cell culture medium used is StemFit For MSC to expand good quality MSC cells. After freezing and clearing all quality control tests, the cells are shipped in frozen form according to the patient's cell infusion requirement. This is the final slide show the criteria of our clinical trial. In inclusion criteria is decompensated liver cirrhosis, and the liver biopsy is not essential. We diagnose liver cirrhosis by CT examination and so on. And also we measured elastography, liver stiffness by 5 scan analysis and so on. The exclusion criteria are not history cancer in the past 1 year, and also no varices that may rupture, and so on. Okay, so I have shared my works using StemFit MSC for good quality autologous bone marrow MSC. So this is my acknowledgement. The center is our current professor, Isao Sakaida. He has flowers because he will retire at the end of this month, just tomorrow. Yes, in Japan, the April is the beginning of new semester. So we are very happy to have, we are able to develop new beautiful medium with Ajinomoto Corporation and take a lead in adapting it for our current clinical trial. Thank you very much for your deep attention. Thank you.
So thank you for hearing our webinar today. I'm Eri Harada from Ajinomoto, and I would like to introduce our medium for 5 minutes before Q&A session. This is StemFit For MSC, which is a chemically defined medium and which has superior cell growth compared to serum-containing media. And in next slide, I would like to explain what is chemically defined. Okay, so what is chemically defined? FBS and HPL, which have been used for MSC culture traditionally, and it contains undefined ingredients. So they have risks of virus infection. In other hand, StemFit For MSC is a chemically defined media, and all components and concentrations are known. So you always get stable results. It does not contain raw materials which have animal or human-derived risks and ideal for clinical application. In MSC therapy, MSC is isolated, expanded, and administered to patients. StemFit can be used for both isolation and expansion processes. We confirmed that StemFit For MSC can be used for isolation from bone marrow and adipose tissue, resulted in a greater number of cells than using FBS. For detailed protocols, please contact us. For superior growth, as Dr. Takami showed, StemFit For MSC improved the cell growth of MSC, which could not expand with FBS. In addition, we have performed cost estimation when increasing bone marrow MSC from 10 to the 6 cells to 10 to the 8 cells. It took about 30 days of 6 passages for FPS to get 10 to the 8 cells, but StemFit could be in 10 days of 3 passages. StemFit for MSC medium was priced higher than FBS plus DMEM, but the total cost including flasks and reagents was comparable. Therefore, StemFit for MSC can be used to stably manufacture cells at the same cost as FBS in a shorter period of time. Thank you very much for attention. And if you have any questions you need more information about StemFit, please contact us. Thank you.